But nice to meet you all. As I said earlier, my name is Brooke, and I'm a licensed certified genetic counselor working for the Smilow Cancer Genetics and Prevention Program. Wonderful team of genetic counselors specializing in hereditary cancer. And we service, I would say, our main site in New Haven, but many different outreach locations. And I'm very lucky to service the outreach location in Trumbull at the Park Avenue Medical Center. And our Smilow Cares discussion presentation today is entitled Family History of Breast Cancer, How Genetic Counseling, Genetic Testing, and a Lifetime Risk Calculation Can Help. I will say, unfortunately, I'm not able to answer any personalized medical history or family history of cancer questions. Highly recommend that you direct those questions to your healthcare providers. And if after discussion they feel that a referral to a specialist, such as a genetic counselor, is necessary, then maybe we'll be discussing further in a genetic counseling session. But we'll go ahead and get started with reviewing some objectives of today's presentation. So first objective being defining the difference between sporadic, familial, and hereditary cancer. Discussing a case exemplifying how genetic testing can play a role in identifying if a patient has hereditary breast cancer risk. Discussing a case exemplifying how calculating the risk to develop breast cancer can play a role in defining if a patient has an elevated lifetime risk to develop breast cancer. And lastly, to describe how medical management recommendations can be modified and personalized depending on genetic test results and or personal or family history risk factors. All right, so in any genetic counseling session, I very much like to review this model with patients. However, I make it a little more fun and I say to envision a pizza pie. So if you envision a whole pizza, that essentially represents cancer diagnoses that have been diagnosed. A majority of that pizza pie, or as we can see around here, 70 to 80% of cancers diagnosed are known as or considered to be sporadic cancers. What are sporadic cancers? Different word that we use in the genetics space. But essentially what this entails are cancers that, we really don't have an answer as to why someone was diagnosed with it. It could be based on numerous lifestyle factors, such as, what we eat, maybe different exercise or workouts. Could also be due to work exposure, alcohol consumption, etc. But we aren't able to pinpoint what exactly caused that individual to be diagnosed with cancer. Now, we're not going to be focusing on sporadic cancers during today's presentation, as we are going to be focusing on first hereditary types of cancer, specifically hereditary breast cancer. Now, what this means, and as you can see, it's like one slice of that overall pizza pie, is between 5 to 10% of cancers, we say, can be considered hereditary, meaning there is a genetic test performed and we are able to identify a genetic mutation or pathogenic variant, as I'll define in a few slides here, that we can say played a big role as to why that person was diagnosed with their cancer. Now, that last piece of the pie, which maybe we can say encompasses 2 slices of pizza, is our familial cancers. And what essentially those are cancers that have been diagnosed in a family, such as a family history, as you'll see in the slides to come, of many different breast cancers or different types of cancers diagnosed. But in those individuals, they've actually undergone genetic testing, but there was no gene mutation identified. And so we would classify that family as a familial cancer family, wanting to adjust their screening, risks, and recommendations appropriately based on their personal and family history factors. And I just wanted to define these terms at the beginning. We'll definitely be going over some details as the slides go on. And as I had mentioned, first, we are going to be reviewing hereditary breast cancer. All right, so the question, right? What do we mean by hereditary cancer? So hopefully any lingering questions will be cleared up after reading this slide. But it's essentially all in our genes. Genes are instruction manuals that help our body function. As we can see here, and probably taking us back to our high school biology classes, genes DNA makes up, or genes are in our DNA, I should say. And so again, instruction manual that guides our body. There are some genes that can relate to how tall we are, how short we are, other genes that can affect the color of our eyes, and other genes that can actually play a role in how our cells grow in our body. And if there is a genetic mutation, meaning something goes wrong, something isn't coded correctly in one of those genes, then maybe our cells' growth go out of control. And as we can see here, cell growth that is unregulated, as we say in cancer genetics, can potentially lead to a tumor being identified, i.e., could be a cancer diagnosis. Now, when we are working with, again, a genetic mutation, or also called a pathogenic variant, as you may hear some individuals in the genetic space refer to it as, genes in our body normally form and code for proteins. And it's actually proteins that work throughout our body and help our body function normally. And so if all of our genetic information was coded absolutely perfectly, we would all have normal proteins and therefore normal body function. Now, let's say there is a specific cancer-related gene that has one of those genetic mutations or a pathogenic variant. That means the protein that is formed by that gene will not function correctly, or there's a higher chance that that person will then have a cancer diagnosis. And so it's that elevated or increased lifetime risk to develop cancer that we are aiming to attempt to identify in individuals who pursue genetic testing and are therefore managed and counseled appropriately by a genetic counselor. All right, now talking about inheritance, because these genes are actually, or I would say normally, not new in individuals who we say pursue genetic testing. They're oftentimes passed down from either their mother or their father. And so if there is a genetic mutation identified in someone who we're ordering genetic testing for, there's actually a 50% chance that they inherited that genetic mutation from their mother, or a 50% chance that they inherited that mutation from their father. And without further genetic counseling and testing of appropriate individuals in the family, it is impossible to determine which side of the family that mutation was inherited from. Now, some ask, why is that important, right? It is important to identify potential relatives who are at risk to have said mutations because, as we'll review later, it can actually affect their medical management and screening recommendations going forward. Now, it's not just important to focus on the generations sort of above our said patient, but also at the same generation, so siblings, brothers and sisters, or even below, their children. There's actually that same chance, a 50% chance that the siblings or the brothers and sisters of said patient identified with the genetic mutation can also be identified to have the same one. Additionally, 50% chance for each child of that patient to have that mutation. And so important that when they are of age, and that appropriate age, we say the individual has to be at least age 18 to consent and pursue genetic testing for a majority of hereditary cancer genes. Until we do that, it's really not possible to determine if they are at that same increased risk to develop the same types of cancers as our patient was identified to have. But again, as we'll talk about a little later, there are sometimes other mechanisms that we can try to assess for in different individuals to see if they do qualify to be in a more high-risk category when it comes to cancer screening. And that type of inheritance that I was talking about earlier, as you can see on this slide, is called autosomal dominant inheritance. Now, the presentation is surrounding breast cancer and family history of breast cancer. So I wanted to make sure to insert a slide that lists some of our more common hereditary breast cancer related genes. Now, a lot of the patients I meet with already come in with a knowledge of the genes right here on the bottom, BRCA1 and 2, or the BRCA genes, which I think is phenomenal. I think knowing about some aspect of hereditary breast cancer genetics is really important prior to going through the process of genetic counseling and testing, as it allows patients to make a really informed decision and choice if genetic testing is right for them, if they are able and willing to be open to hearing potential risk for hereditary types of cancers. Now, also on this slide are genes that maybe individuals haven't heard of before. Genes like ATM. When I use ATM, I normally think of an ATM machine, like for money, but it's actually the name of another hereditary breast cancer gene. Other genes like CHEK2, P10, CDH1, PALB2, again, a slew of letters and numbers, but to genetics professionals like genetic counselors, knowing if a patient is positive for a gene mutation in one of these above mentioned genes can help us determine where they fall in risk category for certain types of cancers. I think honorable mentions are mentioned on that right hand of the slide there for STK11 and TP53, other hereditary breast cancer related genes. Now, the graph, I would say visual here on this slide, demonstrates the lifetime risk percentage of an individual with a mutation in one of these genes to develop breast cancer. And I do just want to point out the elevated lifetime risk for the BRCA genes, as those currently a mutation in BRCA1 or 2 lands at our most highest form of lifetime risk to develop a breast cancer, sitting around between, I would say, between 70 to 80%. And so wanting to make sure, again, that if an individual is positive, that we identify them and can screen them and give them the recommendations that are appropriate for their management going forward. Now, I've been mentioning a lot about genetic testing, and some of you may be thinking, well, how is it performed? How can someone go about getting this done? How can my DNA be analyzed to see if there is a mutation in one of these genes here, maybe some others? So genetic testing is actually pretty simple in how it's performed. Either one tube of blood taken by a phlebotomist, or even potentially self-administered at home by a saliva sample kit that is mailed by one of the laboratories that we use for testing. And clear instructions are provided in that kit for how patients are able to administer the saliva sample themselves, collect it, mail it to the laboratory, and then we're still able to have our consultation over the phone once results are back, similar to if a blood sample was collected during the initial genetic counseling visit. So definitely not as work intensive or invasive as some patients may think. Now, when we do get genetic test results back, I will say not all results are straightforward. So I wanted to make sure to include this visual here in order to represent. There are actually 3 types of results we can get from genetic testing. Now, the most obvious, I would say, are our positive and negative genetic test results. Positive result, meaning a mutation was identified in one of the genes that was looked at on that genetic test. And as I've been saying, if a positive result is identified, medical management could be stratified or changed, and appropriate referrals to high-risk medical providers could be made to help assist the patient in managing their high risk for certain cancers to develop. Now, on the other side of things, a negative test result. This means no genetic mutations were identified on said genetic test that was ordered, meaning there could be no mutations identified in the subset of maybe 5 genes that were looked at, but maybe the whole spectrum wasn't looked at. I would say on average, our panels that we order for our patients involve anywhere between 30 to 50 genes sometimes. And so an overall limitation of genetic testing could be maybe not all genes were looked at that should have been, thereby resulting in a negative test result. However, at that point, when we do get a negative test result, pretty reassuring for the patient that based on what we know, there are no hereditary mutations that have been identified. However, Screening and medical management would then be based off of personal and family history factors as presented below in that arrow. Want to mention specifically that middle test result, a variant of uncertain significance. When I say that during my patient sessions, I always get a chuckle from patients because of course, there is some uncertainty there. We abbreviate a variant of uncertain significance as VUS for short. And what this means is that there was a genetic change that in looking at the genes involved in the genetic test that the laboratory noticed. However, they don't yet have enough data to firmly say, is this result positive, meaning disease causing, or is it negative, meaning it's benign, it's normal? So they classify it in the middle to bookmark that result for themselves, to go back once they test more patients at their laboratory, again, further research the result, to see if it's something that could actually impact patient management going forward for people who do test positive. I will say a huge majority of the time, these test results ultimately get downgraded or moved down to the negative category over time. It's never guaranteed. However, it can happen. I will also say there is a slim but possible chance that VUS results also get upgraded to positive test results, thereby having us recommend medical management changes to the patient at that time. However, I will say, in the meantime, while the result is classified as a VUS, we do not change our medical management recommendations for that patient. We continue to screen and offer recommendations to them based on their personal and family history factors. And I feel like that is the biggest takeaway from learning anything about a variant of uncertain significance. No changes are made to medical management. Now, I think a big question as well is, Brooke, you're mentioning how medical management can change with a positive test result. What are some examples of that? And so listed here and in our bold title rectangles here, cancer screening can be increased in frequency. Risk-reducing surgery could be recommended or considered, or maybe even the option of chemoprevention. Now, some examples of some cancer screening that could potentially change in frequency could be how often you go for mammograms and maybe even an additional breast MRI if qualified. Clinical breast exams, maybe not performed every year, but every 6 months. Prostate cancer screening for men can be initiated at an earlier age than general population. Skin cancer screening for men and women should be recommended every 6 months annually. Ovarian cancer screening could be considered. Pancreatic cancer screening could be considered. Or even an increased frequency in the initiation or carrying out of colonoscopy and upper endoscopy. Some examples of some risk-reducing surgeries that can either be considered or recommended. Of course, this is very dependent on the exact genetic test result that is obtained, but could be bilateral or double mastectomy, or removal of the ovaries and the fallopian tubes. Lastly, some different examples of some chemoprevention options could be tamoxifen and aromatase inhibitors for ER-positive breast cancer risk reduction, or even the administered of aspirin daily. And of course, all of these recommendations are taken and discussed with a healthcare provider before even initiating or starting any of these. Now, I want to get into our case examples because I think these are pretty interesting. And I first wanted to focus on our hereditary breast cancer case example. And so just to give a summary of what's on the screen here, I don't want to read it out as I know you all can see it. But short summary is that we had a 45-year-old female, no personal history of cancer, referred to our clinic, genetics clinic, by her OBGYN. She has a strong family history of breast, ovarian, and pancreatic cancer, and there is thought or consideration for some gynecologic surgery for this patient. So wanting to give the patient the opportunity to pursue genetic testing if she's interested because it may inform her surgical decision making. And I want to show what we call a pedigree or a family tree on this next slide. Now, to everyone else, it's a bunch of circles and squares with some colored in corners. But to genetic counselors, this is very pertinent information and actually adds a lot to our overall risk assessment for hereditary cancer. Now you'll see toward the bottom, maybe a little right-hand side of that pedigree, there is a black arrow pointing to a circle. That is our patient who is referred to us. And this patient is a female, biological female, so she is represented as a circle on this pedigree. The squares are going to be her male relatives. So if you go up a generation, you will see the patient's mother on the right, and then the respective maternal family history. On the left, up on that same level, you'll see the patient's father and all of his relatives to the left of him. Now, you will also see some designations on this pedigree of people who have or who are still living, which means there is no dashed line through their shape, and also people who have cancer diagnoses. The colors of the shaded in regions correspond to the type of cancer they were diagnosed with. So as we can see, the patient's father was diagnosed with a prostate cancer, and so he's designated with blue. Patient's paternal aunt was diagnosed with an ovarian cancer, designated in red. Patient's other paternal aunt diagnosed with breast cancer, the ovarian cancer was yellow, breast cancer is red. And then the patient's paternal first cousin, also diagnosed with breast cancer, designated in red. Lastly, there is another paternal uncle diagnosed with a pancreatic cancer, and that's designated in green. And so this information is talked at length with the patient when she comes into our clinic, discussing, I would say, primarily the BRCA genes, BRCA1 and BRCA2, as some common cancers associated with BRCA1 and 2 mutations include breast cancer, ovarian cancer, pancreatic cancer, and prostate cancer. And I would even like to point out that early onset cancers are also tend to be more closely associated with hereditary causes. And so taking a look at the patient's paternal aunt and paternal first cousin diagnosed with breast cancer, we say any cancer diagnosed under the age of 50 is considered to be early onset. So seeing these cancers were diagnosed at age 45, they do increase our suspicion that maybe there is something hereditary going on in this family. And so when consented for testing, the patient did agree to proceed. We ended up ordering what we call a hereditary cancer panel for this patient, looking at a difference, or I would say a group of 30 or so cancer-related genes, not just related to hereditary breast, ovarian, prostate, and pancreatic cancer, but even including genes such as those related to hereditary colon cancer, hereditary uterine cancer. This patient was very motivated to learn as much of her hereditary risk for cancer as possible. And so allowing the patient the opportunity to pursue such testing is definitely a motivating factor for genetic counselors to express the availability of such testing. And everyone is probably waiting to see what her genetic test results were. So I'm going to proceed to the next slide here. Her results are listed in that white and gray rectangle in the middle of the page. And you'll see the gene on the left that she actually has a positive result in, or a mutation. And some of you may be thinking, hey, that gene looks a little familiar. Well, that's because it was on one of the preceding slides. PALB2 is actually one of the genes that we consider to be a hereditary breast cancer related gene. And you'll see the exact, as we said, pathogenic mutation, pathogenic variant, they all mean the same thing. the exact spot in the PALB2 gene that the mutation was identified in, right there in the middle of that, again, white and gray rectangle. Now, for genetics providers, we use different national guidelines in order to determine how should a person be managed and followed from a national perspective, a national level. And so you may hear some mentioning of the NCCN guidelines, and we look specifically for breast, ovarian, and pancreatic cancer risk. And you'll see to the right-hand side that there are recommendations from a national standpoint for how patients with PALB2 mutations should be followed. Primary breast cancer risk, as you can see here, is between a 41 to 60% lifetime risk to develop breast cancer. To put it into perspective, general population risk, meaning no hereditary breast cancer mutation identified, is somewhere between 12 to 13%, or you may even hear it in a ratio format of 1 in 8. So, what we would classify as increased risk is definitely represented by an individual with a PALB2 mutation. Now, there's also a risk for additional breast cancer diagnoses in the future. And so wanting to make sure that the patient is counseled and referred appropriately to high-risk breast providers, which there are amazing high-risk breast providers at the Park Avenue Medical Center in Trumbull who meet with these patients and who we refer these patients to in order to have these discussions surrounding increased screening frequency and also consideration of preventative breast cancer or breast surgeries, such as one of those risk-reducing mastectomies. You'll also see there's risk for men to develop breast cancer if they are identified to be positive for a PALB2 mutation. So this further emphasizes the importance of genetic testing, even if there's only family history of female breast cancer and ovarian cancer, that men should also be pursuing genetic testing should there be risks identified in their family. They could also be at risk for certain types of cancers. Now, I want to mention with PALB2, while we're focusing on hereditary breast cancer on this particular slide, on the next slide, you will see that there is risk for other types of cancers if people are identified to have a mutation in this gene specifically. You'll see on the left, ovarian cancer risk. We do know that there is an elevated lifetime risk for women to develop ovarian cancer. We say between 3 to 5%. And again, this screenshot was taken from those same NCCN guidelines. And so for women identified to have a PALB2 mutation, we do often place referrals to gynecologic oncology in order to have more in-depth discussions about risk-reducing gynecologic surgeries, such as removal of the ovaries and the fallopian tubes. Now, the second square here, we see pancreatic cancer risk and management. Yes, there is also increased risk for individuals, men and women, to have and develop pancreatic cancer in the future. We say the absolute risk currently sits at around 2 to 5%. And so wanting to make sure that we plug patients in to high-risk pancreatic cancer screening availability through the Yale Medical Center would be important in order to initiate pancreatic cancer screening should they qualify at an appropriate age. And I will just make a caveat and say these risk percentages change. Maybe in 1 to 2 years, these risk percentages will go up, go down. But currently, these are said risk percentages, and it also aids in the ongoing education and research that goes into the associated cancer types when it comes to these genetic mutations. Genetics is definitely not a stagnant field, constantly learning so much about genetic mutations, even those that have been discovered years ago. And so wanting to make sure that if you have any sort of inclination to check in about genetic mutations, if you are identified to test positive, you check in with your genetics providers as they would be the most up to date about current cancer associations and risks associated. All right, going back to our pedigree or our family history here, We identified that our patient right here with the black arrows PALB2 positive. And so wanting to now identify who else in the family may have tested positive, should they have pursued testing, / who should be pursuing testing at this time in the family. So I have some red squares here to kind of demonstrate. Some of these people are passed away, so they are unfortunately not present to be doing genetic testing. But if they were to be still living, wondering if maybe the paternal aunt with ovarian cancer or the paternal uncle with pancreatic cancer may have also tested positive, I think there would be a likely chance that they would have. Now, our individuals who are still living, the paternal aunt with breast cancer and the paternal first cousin with breast cancer, would be great next candidates to consider pursuing genetic testing for the PALB2 mutation. Now, notice that the patient's father is not highlighted. I will say it is because, one, prostate cancer is not currently known to be an associated cancer with PALB2 mutations. However, growing evidence and association that it might be in the future. However, we do not base that in our risk assessment for a PALB2 mutation. Now, let's say one of the paternal aunts was identified to test positive for the same exact PALB2 mutation our patient had. That would actually make our patient's father, if he were alive and available for testing, he would more than likely test positive for the same mutation. Because again, going back to our autosomal dominant inheritance, this mutation had to have come from someone, mom or dad, in order for our patient to test positive. And so if a sibling of the father tests positive, then our patient's father would have had to test positive in order for our patient to test positive. Okay, we're transitioning now into a different section of today's seminar, talking about familial breast cancer risk. So referring back to our pizza pie analogy, going for that, around 20% of cancers are considered to be part of or grouped into familial cancer. And we're going to kick this section off with another case that describes familial cancer. And so again, summary of the case presentation listed here. A 68-year-old female, again, no personal history of cancer, is referred to our genetics clinic by recommendation by her 40-year-old daughter's OBGYN, based on the family history of breast, ovarian, and prostate cancer. She was told by her daughter that she had to pursue genetic testing for the breast cancer gene in order to inform her daughter how she should be screened for breast cancer going forward. And before I move on to the family tree or the pedigree, just to point out here, I would say that the daughter's OBGYN was curious about mom's, so the 68-year-old female's status for potentially hereditary breast cancer, because screening initiation via mammogram for general population women, meaning no cancer mutation identified, begins at the age of 40. So this patient's daughter would be at the exact age to begin breast cancer screening should there not be a genetic mutation identified. If there were to be a genetic mutation identified, there may be some changes to her screening protocol moving forward. So important information. Now here is the family tree presented. We have our patient over on the far left-hand side, and as we can see, a majority of breast cancer, even some prostate cancer diagnoses in the family. And so I'm not going to go as in-depth with this family tree as I did the last one, but just know the patient did receive full counseling and consent to pursue genetic testing, and her results are listed here. And you can see that there were 2 uncertain test results, or a couple of those variants of uncertain significance. Now, if you remember back from the slide before, we do not change medical management for variants of uncertain significance. We treat them as non-actionable genetic test results unless we are notified otherwise in the future. And this patient was tested for a big, broad panel of different cancer-related genes, and so feeling pretty confident that everything was looked at by the laboratory that needed to be based on the family history. Now, some of you are probably thinking, but this patient's family history looked suspicious for hereditary cancer risk. Well, I was thinking the same thing. But Possible explanations for an uninformative genetic test result. We didn't find a genetic mutation related to hereditary cancer. Possibility one is the cancers are in fact not hereditary. The most likely explanation is actually possibility number one. But these cancers in the family could be caused by a combination of factors, environmental, lifestyle, as we mentioned before, or sporadic cancer characteristics. Another possibility could be the wrong person, our patient, was tested in the family, and there's actually a pathogenic variant that could be identified in another family member that could increase cancer risk from a hereditary perspective. Possibility three, there's a pathogenic variant in a different gene associated with an increased risk to develop hereditary cancer that hasn't been discovered or tested as of yet. So a limitation overall to genetic testing. Or a last possibility, a pathogenic variant is in the family, but our current genetic testing technology is not able to detect it. So what is our overall solution? Test the most informative relatives next and offer screening recommendations to our patient and appropriate relatives based on the patient's personal risk factors and family history of cancer. So wanting to bring it back to the family tree here, again, our patients on the left-hand side, and you'll see the red boxes float up. As these patients as our patient's siblings and relatives are still living, such as her two brothers with prostate cancer, one sister with breast cancer, and a maternal first cousin with breast cancer, they would be the next best people to pursue testing. I also wanted to point out, especially for the patient's sister, so with the red corner on the left, still living with the box surrounding her, per the notes, she previously pursued genetic testing for the BRCA genes, and she was negative. Now, wanting to make sure that we also encourage these individuals who had genetic testing maybe 15, 20 years ago to reconsider pursuing genetic testing again in a more panel format, making sure to look at all of the genes related to hereditary breast and prostate cancer based on the family history to make sure that there is a comprehensive genetic or hereditary risk assessment that is provided to that patient based on what we know of now in 2024 that we may not have known of in 2004 when they may have pursued testing in the past. All right. Now, you heard me mention the patient should be screened based on personal history factors and also family history factors, including family history of cancer. What does that mean in terms of risk stratification and why we do so? So our national guidance is that if a risk percentage is determined to be lower than 20%, the patient being assessed is over the age of 40. And again, the percentage is under 20%. Annual mammography or mammogram screening by the age of 40 should be initiated, or about 10 years prior to the youngest breast cancer diagnosis in the family. But we make sure to not initiate mammography screening before age 30. Other forms of screening will be recommended or offered to said patients, and I'll go over that in the next slide. Now, if a patient's risk is determined to be higher or greater than 20%, and they are over the age of 40, which again is our national screening recommendation age initiation for general population women. You begin annual mammography screening by age 40, or again 10 years prior to the youngest breast cancer diagnosis in the family, not before age 30. And here we consider adding on a breast MRI, a different form of screening in addition to annual mammography screening. In this case, one form of screening, let's say a mammogram, will be performed in January, 6 months later in June, breast MRI, rotating every 6 months as such. Now, for patients being assessed who are younger than the age of 40, what would we recommend? We encourage mammography screening initiation, again, based on family history of breast cancer, since our risk calculation is not validated for women who are not of age to receive mammography screening, either by general population guidelines or even family history of breast cancer. And so by the time that individuals are going to be initiating their annual mammography screening, consideration of a risk calculation can be performed at that point to determine if more screening, such as via breast MRI, is indicated for those patients. So wanting to make sure that we are not calculating lifetime risk to develop breast cancer at too young of an age, but just at the age that is correct for that woman to begin her mammography screening. I'm talking a lot about risk calculations, and some people may be wondering, how do we determine that? What is a lifetime breast cancer risk assessment? And again, this is actually, this was inspired by recent coming forward of a very famous actress, Olivia Munn, when she came forward with her breast cancer diagnosis. And I wanted to include some images from her personal Instagram page where she was like one of these patients that we have talked about. In her story, she describes undergoing genetic testing, pretty big panel of genes. She says 90 different cancer genes, and she was negative, her and her sister, as we can see here. They were very excited. However, a couple months later, she discloses that she was diagnosed with breast cancer. And so going through this diagnostic odyssey of thinking that she was in the clear for breast cancer, but then later being diagnosed after, as you can read on the next slide, she had her lifetime risk for breast cancer calculated by her OBGYN. Based on her elevated lifetime risk being over 20%, she quotes it as 37%. She qualified to pursue a breast MRI in addition to her mammogram. Now, she mentions that her annual mammogram was clear. I believe Olivia Munn is around 43 years old, so she is right on track to be pursuing annual mammograms. However, when her lifetime risk to develop breast cancer was identified to be 37%, her OBGYN referred her for a breast MRI, which ended up identifying her breast cancer diagnosis. Now, Olivia Munn's story, unfortunately, is not unique. I would say many women pursue hereditary cancer genetic testing based on family history of breast cancer and are under the incorrect assumption that they will never develop breast cancer, or they may have a lower lifetime risk than maybe some other relatives who have a personal history of breast cancer. Mammograms are typically reliable to detect abnormalities in the breast tissue of women considered to be at, again, general population risk to develop breast cancer. However, other forms of imaging, such as a breast MRI, which is what ended up identifying Olivia Munn's breast cancer diagnosis, may be beneficial to women, in addition to the annual mammogram, as I said before, who are considered to be at increased risk. Not all types of breast cancer, such as the luminal B type of breast cancer that Olivia Munn was diagnosed with, have direct hereditary association at this time, meaning there's a lot more that we still have to learn from the hereditary breast cancer perspective. And there's so much more to be discovered when it comes to different genes that may be implicated with hereditary breast cancer, even more to discover based on the genes we already know about. And so wanting to make sure that individuals have very personalized family risk assessment, personal risk assessment for cancer screening management that's appropriate for them is of utmost importance and highly valued by cancer genetic counselors and other medical providers who we work with very closely. So enter, if you've heard of this before, Tyrer-Cuzick. What is this risk calculator? And I put in a screenshot again from Olivia Munn's personal Instagram page. She is a huge patient advocate right now for the utilization of the Tyrer-Cuzick breast cancer risk assessment model. What it essentially is it calculates lifetime risk for women to develop breast cancer based on a personal history factors and family history of breast cancer. Some may be wondering, what do personal factors include? Could be the woman's age at the time that the risk calculation is being performed, height and weight, age at which they got their first period, age at which they went through menopause, or if they are in menopause, if a biological child has been conceived and at what age, whether or not the woman has had a breast biopsy, the mammographic density that is determined after undergoing a mammogram, if the woman has used hormone replacement therapy in her prior history or currently, and also the results of genetic testing. Some family history factors that may be included are the number of biological female relatives in the family, age at diagnosis of breast or ovarian cancer in other relatives within a couple generations, and then also the results of family member genetic testing. And I want to take you through what the medical provider who puts in and plugs in all of this data can see from the calculator perspective. So I actually do this, I would say, on a daily basis for patients who I meet with. And it's important that we assess patients with no prior history of breast cancer themselves. So this is what a calculator looks like before you put in any information. So just when you bring it up on your screen. And so you'll see all of those personal history factors and family history factors on the left-hand side that I just listed out to you all. On the right-hand side, as you put in the data, it will kind of populate on our pedigree or family tree in the lower right-hand corner. So I've kind of mocked up a patient here just to show you how it can change. So in this case, the woman that I am calculating her IBIS score or Tyrer-Cuzick score is, she's 43, got her first period at the age of 12, unknown height or weight. She had her first child at the age of 41. She's had no breast biopsies. She is premenopausal, meaning she still gets her periods. Her breast tissue is considered to be heterogeneously dense, and that could be obtained from a mammography report. And I detail here the family history we do know. She has 2 sisters. Neither of them have been diagnosed with cancer. Our patient specifically has undergone genetic testing and she's negative. However, 2 of our patient's maternal aunts were diagnosed with breast cancer at the ages of 45, both of them. So as we talked about at the beginning, considered to be early onset breast cancer diagnoses for 2 of the patient's aunts. Now, once we're done imputing or putting in all of this information, the whole calculator will calculate the overall lifetime risk for that woman to develop breast cancer, and that's on the upper right-hand corner there. So once we do that, we get this screen appearing. And you can see from on the upper part of this diagram here, our 10-year risk for the woman to develop breast cancer is 4.5%, and her lifetime risk is going to be 22.2%. And so based on our knowledge of over 20% or under 20%, this patient would qualify for the over 20% lifetime risk category. Therefore, she should be offered the consideration of adding on a breast MRI to her annual mammogram. Now, Tyrer-Cuzick is not the only thing out on the market here for other risk assessment tools. Other medical providers may utilize some of these other tools in order to try to gauge a woman's lifetime risk to develop breast cancer. Such things as Klaus tables or the Gale model. Klaus tables are actual tables that are very outdated, I will say. It provides stratified breast cancer risk by the person's age. Pretty easy and quick to use for a risk estimation. And however, it does not incorporate any personal history factors, nor does it incorporate any risk from family members diagnosed with certain types of cancer besides breast cancer. The Gale model, on the other hand, kind of a pro for this model is that it incorporates personal history factors. So similar to Tyrer-Cuzick, unlike the Klaus tables, however, does not account for breast cancer history in relatives past the first degree. First degree relative examples would be mother, sister, daughter of the patient. It also does not incorporate risk from other cancer types besides breast cancer. And so that is why our clinic decides to go forth with Tyrer-Cuzick as our risk assessment model. Now, how is medical management personalized based on the risk score that a patient gets from the Tyrer-Cuzick risk assessment? And so we've constructed a little pyramid here to show this. If your lifetime risk to develop breast cancer is under 20%, again, annual mammography screening. If your lifetime risk to develop breast cancer is between 20 to 50%, annual mammography and annual breast MRI can be considered to be added on to that regimen. Now, if a woman's risk is over 50% in the lifetime to develop breast cancer, Maybe not just increased breast cancer screening via annual mammogram and breast MRI, but also the consideration of some chemoprevention tactics, like we discussed in one of the prior slides. Additionally, there may be some consideration and discussion surrounding some surgical preventative options through a bilateral double mastectomy. But these decisions are not made in a vacuum. There are very supportive teams, including cancer genetics, could also be, again, the breast specialists at the Park Avenue Medical Center that talk with women about different options that they can take based on their personalized risk score. And at the end of the day, family history of cancer. What do we do? What do we recommend that you do? Speak with your providers, such as an OBGYN or a PCP, who you meet with in greater frequency. Report any personal or family history factors that I may have mentioned today that you've maybe come to realize are in your personal or family history to help your medical providers determine if you and your family may benefit from additional cancer screenings, a different screening frequency, or maybe even hereditary cancer genetic testing with either myself or one of my colleagues. Remain up to date and knowledgeable about your recommended screenings. So for example, take initiative in scheduling your annual mammograms and know in how many years you are due for your next colonoscopy instead of waiting for the doctor's office to give you a call to schedule that screening exam. And lastly, come visit us in the Smilow Cancer Genetics and Prevention Program for a hereditary cancer risk assessment by a genetic counselor. We'd be happy to see you, discuss your options with you, and also provide you with a more personalized risk assessment based on personal history and family history factors. And I thank you all for your time today in listening to my presentation. Again, I'm a genetic counselor within the Smilow Cancer Genetics and Prevention Program, and I've listed our clinic phone number and our clinic fax number on this slide in case there are any questions or anyone needing to figure out how a referral should be placed to our clinic. And I thank you.